Can everyone hear me okay if I'm not using the mic? Okay. So the first talk is going to be on the total joint clinical pathway with a focus on the postoperative care. So with the total joints care team, we've got an ultimate goal. And this is mainly focusing, when we talk about total joints, this is going to be mainly on total hips and total knees. But our ultimate goal here is to improve the quality of life of our patients by relieving their pain, improving their mobility, and restoring function so they may return to the activities they love more quickly. In order to do that, this team takes a lot of players. We need a specialized team of nurses, physical therapists, occupational therapists, social workers, case managers to focus on the entire spectrum of care, not only the postoperative care, but the preoperative care, rehabilitation, and the emotional needs of our patients. And total joints is a passion of mine. I did a fellowship in adult reconstruction focusing on knees and hips, and this is why I come to work every day.
My name is Lisa. We're on our family dairy farm. The knee pain started abruptly when I was walking. My knee was given away and it just didn't feel right, so I went to see an orthopedic surgeon about replacement. He said I would decide when the pain was bad enough. So for about a year, I struggled with just daily activities. So I called him and I said, I think I'm ready. I think I want to have my life back. After my second knee surgery, I was driving a tractor all day long. I had to pinch myself almost because I thought, wow, this is great. Getting my knees replaced allowed me to do my job, which I think has helped feeding the world.
So that's why we do it. We do make a big difference on our patients. And again, this talk's going to be on the postoperative care, but in order to understand the postoperative care, I think we need to also understand our total joints clinical pathway. What are we doing from beginning to end? And there's a lot of factors that are involved with this. There's patient education, the case management aspect. What are we doing for pain management throughout the entire course of care? What are we doing for nausea and vomiting? How are we managing our blood? Are we giving transfusions too frequently? Not enough? Are we identifying people with anemia? What type of anesthesia are we using? What's the surgical technique? Physical therapy and occupational therapy are very important, not only after surgery, but also before surgery. Orthopedic nursing is especially important. And then communication amongst all the team players to make sure we're all on the same page. So you can divide the total joints pathway into phases. You've got your preoperative phase, the intraoperative phase, and the postoperative phase. And with the preoperative phase, starts with patient education, setting realistic expectations. That starts at time 0, which is at the moment they schedule surgery with us. We do a comorbidity assessment. We're trying to improve and identify what some modifiable risk factors are. And we'll talk about this on the postoperative care as well, because that's important when you're taking care of your patients. Not every patient's the same, even though you may have 3 new total knee replacements or total hip replacements. You want to identify with each individual patient within that continuum of care who may be at higher risk of having blood sugar problems, who's at higher risk of respiratory depression, maybe they have sleep apnea. So those are things postoperatively that we need to be aware of. Anemia detection preoperatively helps avoid blood transfusion postoperatively. And then preemptive pain management. If somebody's been on narcotics before surgery, they're narcotic tolerant, your postoperative pain pathway that you typically use is not going to work. So that's something you want to identify on postoperative day 0 so you can stay ahead of the game. Intraoperatively, we use good surgical technique, multimodal analgesia. We start our nausea and vomiting prophylaxis before surgery. Active warming is very important, blood loss prevention, and the type of anesthesia that we use. Postoperatively, multimodal pain management, nausea, vomiting prophylaxis, our physical therapy and occupational therapy. Really, with all of these, our goal is for early mobilization. If we can get our patients up postoperative day 0, the same day they had surgery, they're likely going to recover faster, go home sooner, and be safer throughout their postoperative care. Early education helps to achieve those goals. Medical optimization, again, starts preoperatively, but also continues throughout the continuum of care. And then early safe discharge ultimately is our goal. So with patient education, again, that starts in the office. That starts with me It starts with educating the patient. How long are they expected to stay in the hospital? Historically, people would stay in the hospital 3 to 5 days, but with our new rapid recovery models, patients are sometimes ready to go the very same day of surgery, and there are some outpatient total joints that are going on. Our average length of stay is 0 to 2 days, but we want to start educating the patient so they have realistic expectations. If a patient thinks they're going to stay in the hospital 5 days, they have very little motivation to move on the day of surgery or the day after. They're going to want to just have their water, watch TV, and just be pampered a little bit. But if they know that the goal is to go home and they know that leads to a quicker and safer recovery, now you've got them motivated and now they're part of the team actively trying to help with their recovery. Ultimately, our goal is for a fast, safe return to function. And again, this needs to be reinforced by all the staff throughout the entire continuum. If one person says they're going to go home at one day and another says they're going to stay a week and another says they're going to go to a rehab center and then another says they're going to go home, now the patient's confused. That increases their anxiety, and anxiety has been shown to increase complications. So how we prep for surgery, educational classes before surgery is very important. We teach the patient what to expect the day of surgery, what the recovery room is like, what the hospital floor is like, setting realistic expectations. We do very well with our joint replacements, but it does not give a 75-year-old patient with multiple medical comorbidities their 18-year-old knee again. And if they think they're going to get their 18-year-old joint and go run a marathon afterwards, they're not going to be happy and their expectations won't be met. So we want to make sure we're all in alignment with realistic expectations. An educated patient, again, is a more satisfied patient, decreases anxiety, helps with that psychological component, and we want to be consistent across all of the team players with this message. So preoperatively, physical therapy is very important. We want patients to start practicing the exercises before surgery. Now, it may not be the same exercises they're doing after surgery, but going through the motions, learning what it feels like to activate their quadriceps muscles before they've had a traumatic surgery to their body will help them in the recovery phase. It'll also help gain a little bit of muscle tone, maybe a little bit of strength, because a lot of these patients are deconditioned at baseline. So a month of therapy before is just like professional players do training camp before they go start the season. So it's very important. We want to educate the patient about discharge before surgery. If patients given no thought what they're going to do after surgery until after surgery, that's likely going to lead them to having increased anxiety because maybe they didn't get a shower chair, they didn't anticipate who was going to drive them home. These are all things that can easily be planned and communicated and educated to the patient before surgery. We want to identify if there's any necessary equipment they may need, such as a walker, toilet seat, or a shower chair. If there are, these are all things that the patient can get before surgery, and again, on the postoperative side, this is going to help that continuum and make that postoperative care that much easier. So one of the other important factors is our communication. It's our job as orthopedic surgeons, as well as the primary care physicians and anesthesiologists, to have good communication, and sometimes we don't have good communication, and this is a good example.
There is a fracture. I need to fix it.
Can you tell me more?
The fracture is very displaced. I need to fix it.
Okay. Let's start from the basics. Where is the fracture?
The fracture is in the emergency department. I need to fix it.
That's not what I meant. Who does the fracture belong to?
The fracture belongs to a bone. The bone is a femur.
And who does the femur belong to?
So that's a communication between maybe an orthopedic surgeon and an anesthesiologist that don't have good communication skills. But there's actually a 3-minute or longer video of this, which is really funny, but it does reflect on sometimes the poor communication the providers have. And this is important because we want to identify what the risk factors these patients have before surgery. If they're modifiable and correctable before surgery, this again is going to lead to an improved postoperative care. So urinary tract infections, what defines that? How are we going to treat that? Diabetes, if their A1C is 10 or 12, that's probably somebody that does not have good glycemic control, and their surgery needs to be postponed until they do. By identifying these, that postoperative care is going to be that much better with lower complication rates. What are we doing for MRSA screening? What are we doing for preoperative anemia? If a patient comes in with a hemoglobin of 13 or higher, the incidence of needing a blood transfusion is less than 3%. If it's 11 it's a 50% chance of needing a blood transfusion. So identifying these people before surgery will significantly, again, improve their recovery. Sleep apnea is another one. Patients with sleep apnea after anesthesia having narcotics are probably need to have closer respiratory monitoring overnight, especially that first night. Pain management is especially important with orthopedics. We want to help control the pain before it gets out of control. So we have a multimodal pain program that we recommend. It's a combination of anti-inflammatories, spinal anesthetic, a local anesthetic injection given at the time of surgery. Tylenol is very important with this. And then there are narcotics, but we try to minimize our narcotics. So there's central acting narcotics like Ultram, and then other opioid narcotics such as Norco, Percocet, or Roxicodone. Preoperatively, we'd start our patients on an anti-inflammatory loading dose of Celebrex as long as they don't have a sulfa allergy, 400 milligrams 4 days prior to surgery. And again, the preoperative exercises, if they're able to do those, that can help with their pain control as well. The morning of surgery, we do a multimodal approach, and again, we're trying to attack the pain pathway from multiple different angles. So anti-inflammatories with Celebrex, Oxycontin is a long-acting pain management medication, Tylenol, and Tramadol. So we're trying to attack the pain pathway from all of the different directions, and by doing that, we can minimize the narcotics. And as we all know, narcotics are a big deal in healthcare, and it's a big deal for our patients getting addicted, having constipation, and other associated problems with the narcotics. Intraoperatively, we do an injection around the injection site or around the surgical site, whether it's the hip or the knee. So ropivacaine, epinephrine, depomedrol, Toradol, morphine, a combination of those medications based on risk stratification of those patients. If they have renal failure, for example, we wouldn't use something that's potentially nephrotoxic, such as Toradol. If they have significant cardiac history, we may not use the epinephrine to help vasoconstrict, and so forth. Postoperatively, we have a scheduled program. We do scheduled Tylenol, scheduled Ultram, scheduled Celebrex. By getting the patients on a scheduled pain program, that's going to limit the need for those stronger narcotics that have the side effects. Don't typically recommend PCAs. I think the trend nationwide is to get away from those, as well as the indwelling catheters. We want to try to get our patients disconnected from as many tubes and lines as possible postoperatively. Typically discharge our patients home on Celebrex, Ultram, and then Norco as needed. Using this program, we have lots of patients that they'll take a Norco prescription, but typically only are taking Tylenol and their Celebrex postoperatively after a major joint replacement. Nausea and vomiting prophylaxis is extremely important. Some people would prefer to have pain than be nauseous. So we want to try to prevent the nausea before it starts. So that starts in the preoperative holding. We give patients scopolamine patch. Intraoperatively, we're giving them an IV steroid dose. That's been shown to help with the inflammation, the anti-nausea properties, as well as the pain management. Zofran is given as well, which is an antiemetic, and then also appropriate fluid management. If you maintain a normal volemic status of our patients, that's going to help with their postoperative nausea. Postoperative day 1, we continue that with the scopolamine patch, give an additional dose of steroids, and also make sure that they're starting to tolerate their PO diet and fluid intake. So surgical technique is very important, and there's different techniques with total knees and total hips, but ultimately the goal is the same. We want to preserve our soft tissue planes, minimize the soft tissue trauma. Tourniquets on knees, there's a trend now going away from tourniquets. I personally still use a tourniquet, but it's very interesting to me, and as a resident, we all would put tourniquets on our legs and inflate the tourniquet to the level that we would do the surgery. And if you're ever interested in how painful that is, I would recommend trying it because it's very painful. So you're doing a knee replacement on a patient and squeezing this big strap around their thigh. A lot of times patients' knees feel fine after surgery, but their complaint is of thigh pain, probably coming from the tourniquet. We want to control our bleeding during the surgery. We want to restore the joint's biomechanics with soft tissue tension, implant sizing, positioning, and secure implant fixation. The type of anesthesia is also important, so a spinal or epidural anesthesia. We want to have a hypotensive anesthesia that's going to minimize our blood loss. Intraoperative IV steroids for the nausea and vomiting, And then we've, over the past 3-4 years, tranexamic acid has become very popular with hips and knee replacements. There's a lot of different algorithms for this. We typically do 1 gram before surgery and 1 gram at closure, although the studies show that whether or not you do 2 before, 2 after, 1 in the middle, or even give topical, it's all been shown to be beneficial. We don't quite know yet which way is beneficial, but we do know it helps with the blood management. DVT prophylaxis is a very big component of total hip and total knee replacements. The ACCP and AAOS guidelines have changed over the past few years, and in 2014 they actually approved the use of aspirin for DVT prophylaxis. Aspirin is one of my favorite medications for DVT prophylaxis because it has a very low bleeding profile, so we're not getting big hematomas after surgery, we're not losing a lot of blood after surgery, and it's still providing that anticoagulation that's needed. Part of this component, though, is everything else that goes along with that patient. Mobilization of our patients is probably the main reason why the DVT rate nationwide has gone down. Historically, patients would stay in the hospital and stay in bed for 2 to 3 days before they would get mobilized, and that's where all the historical data from the high incidence of DVTs came with total joints. So what do? I risk stratify my patients if they've had previous blood clots or PEs, if they have any blood dyscrasias such as protein C or S deficiencies, factor V laden, if they have any active cancers that are going on. Those are patients that likely need a higher anticoagulation. If it's a standard risk, aspirin's just fine. So again, we use a multimodal approach for our anesthesia. With our DVT prophylaxis, spinal anesthetics has been shown to actually decrease the rate of DVTs, so we typically recommend a spinal. We use foot pumps, early frequent mobilization, and again, the standard risk is aspirin, 325 PO/BID. If they're a high risk, a higher anticoagulant such as Eliquis, Coumadin, or Lovenox. So these are things, again, post-operatively, you want to identify the patient, see what they're on. Every patient needs to be on some DVT prophylaxis, but maybe the physician has them on aspirin and you identified that patient as previously having had a DVT. That would be a good reason to contact your surgeon and double check. Are you sure you want them to be on aspirin? They had a DVT or PE that wasn't noted in the chart, but they told me when they got up to the floor. Blood management's very important. If a patient's needing a blood transfusion after surgery, they're not able to mobilize, they're not able to do physical therapy, it's going to lead to a longer length of stay. It's also going to increase their comorbidities because getting a blood transfusion is not a benign procedure. We start with a comprehensive program. Preoperatively, we want to check their hemoglobin. Again, if they have a low hemoglobin, they shouldn't be having an elective surgery. We used to screen for iron deficiency, but insurance companies recently have made that very difficult, making the patients pay out of pocket. So now we prophylactically treat everybody with iron supplementation because the age population in general, the majority of the time, has some iron deficiency to help bring their hemoglobin up. There's other treatments such as Epogen if needed. Jehovah's Witness, for example, who's said they're not going to get a blood transfusion after surgery. We definitely want to make sure that their hemoglobin is higher. Intraoperatively, we try to do a lot of things as well. As previously mentioned, the spinal anesthetic, hypotension is very important. The tranexamic acid has significantly decreased the rate of blood transfusions since its implementation. Our surgical technique's very important. We have bipolar sealant devices that we can use, and then there's also topicals that can be used as well. So again, multifactorial, lots of ways, but very important because we want to avoid those blood transfusions and that blood loss postoperatively. When I was a resident, our triggers used to be a hemoglobin before 10, everybody got a blood transfusion. But I think a lot of that has changed. If somebody has low blood pressure or seems symptomatic right after surgery, it's not likely because of a low hemoglobin. It's likely because they have not been appropriately fluid resuscitated. So these are some of the guidelines that we use. So under 7, most would agree that would be appropriate to transfuse at least 1 unit. 7 to 8 with symptoms, you want to reevaluate and look what their fluid status is. Maybe they just need to be fluid resuscitated. If they do have persistent orthostasis, dizziness, fatigue, that would be an indication to give a blood transfusion. And a blood transfusion doesn't always mean immediately give 2 units. Sometimes maybe they only need 1 unit. So with our pathway going from preoperative, intraoperative, and postoperative, Again, with the postoperative care, there are a lot of factors that we need to be evaluating. We want to do a physical assessment and treatment with the patient. Psychosocial assessment is very important. Anxiety and depression have been shown to increase the complication rate on total knee and total hip replacements. We want to make sure all of their lab work, if done, is appropriate. Again, pain control is especially important. Their nutrition is important. Are they having bowel movements? Are they voiding? What sort of activity are they doing? We want to be educating them all throughout this course. And then again, discharge planning. And discharge planning really can be expedited by having a good game plan tentatively before surgery, and then that can be modified throughout their continuum of care. So with the physical assessment and treatment, you want to be evaluating the patients on continuously throughout the day. You want to check them morning, midday, and evening assessments. You want to be doing your vitals. You want to make sure they're having appropriate respirations, coughing, deep breathing. This is another reason to risk stratify or identify your patient. What type of anesthesia did they have? If they had a general anesthetic, probably even more important to encourage the incentive spirometry and the coughing and the breathing. You want to check their lungs. You want to see what their I's and O's are, make sure they're appropriately fluid resuscitated. And again, nausea and vomiting assessment, bowel movements, voiding, all of those are very important for the patient. You want to be evaluating for any skin breakdown. Are they getting breakdown on their heels or on their sacrum? Are they wearing their TEDs? Now, TED hose don't do anything with DVT prophylaxis, but they do help with the swelling. So if the TED hose are too uncomfortable and the patients don't like them, there are other swelling treatments that can be done. ACE wraps can be used instead, for example. You want to check if the patients are alert and oriented. An elderly patient who's never had any narcotics, never had a surgery before, even a low dose of a narcotic and the anesthesia they're getting could impair their cognitive function. They may try to get out of bed and think they're at home and have a fall. We certainly don't want to have a fall right after a surgery. Neurovascular checks are extremely important. The wound bandage, you want to make sure that their incision is clean, dry, and intact. And also, again, the pain assessment. So the psychosocial assessment is important and something we try to identify, again, in our comorbidity risk stratification before surgery. Is this a patient that has known anxiety, known depression? Are they on medication? If they have known depression and have never been evaluated, that's something that should be done before surgery. At the time postoperatively, even if they've never had those diagnoses, it's very common to have anxiety and feeling nervous or even agitation after having a major surgery. We want to make sure that they're coping with this effectively. Are they sleeping? Do they need sleep medication? Are they having any other cognitive impairments? So our tests, if a patient's had a revision knee or a hip replacement, cultures need to be followed. If there's any abnormal cultures, that would be a reason to contact your surgeon. Following the hemoglobins, transfusions, other abnormal labs. Kidney function is one of the big labs that are important for our patient population. They're receiving medications that potentially can be nephrotoxic. They're potentially having low blood pressure during the surgery. If their blood pressure was maybe lower than it should have been, that potentially could be traumatic to their organs. So those need to be monitored postoperatively. So with the pain control, with physical therapy, typically we like to make sure they're getting some sort of pain medication 30 minutes before surgery. This allows them to do the physical therapy that's needed to get them up and mobilize. Ideally, our goal would be to have the patient's pain level below 3. Cryotherapy or cold therapy has also been shown to be effective. You just need to make sure that cold is not on the skin for too long, because patients can get frostbite if it's left on for a prolonged period of time. So again, the nutrition of the patient and the elimination is very important postoperatively. We've just had a very high metabolic insult to the patient with a traumatic surgery. They are going to need a lot of calories, healthy nutrition, in order for their body to heal appropriately. We also need to make sure that they're voiding appropriately and having bowel movements, because what we did with surgery can cause urinary retention, can cause constipation. So usual diet's important, and I'm sure you guys can attest, a patient that's had a surgery in the afternoon that's been NPO all day, they're very hungry when they get up to the floor, to the point that they're even starving. But it's hard to eat if you're feeling sick, so you want to make sure, again, our nausea and prophylaxis is under control. We want to make sure they've got good bowel sounds. And then if they are poor bowel sounds and they need a laxative, you need to properly educate the patient and let them know how the laxative works. So Foley, should we use them or shouldn't we use them? We're trending away from using the Foley catheter. This is all of the decisions we make post-operatively are not benign decisions. There's risks and benefits to all of those decisions. So inserting a Foley's not benign. You can cause traumatic injury, especially if it's a male with a history of prostatic hypertrophy or any prostate surgery. They're at risk for getting urinary tract infections. Not using a Foley is also not a benign decision. There's an incidence of urinary retention, and if that bladder gets too distended, you can get what's called a neurogenic bladder, where they'll no longer be able to actively urinate afterwards and have to straight cath for the rest of their lives. That's a pretty big problem. So having a good bladder program, bladder scanning, staying on top of that is extremely important. Not using a Foley, on average, nationwide statistics shows about a 10% incidence of requiring at least one straight catheterization postoperatively, but they would still argue in the literature that that is still less than the risks associated with using the Foley. So activity and therapy, we want to have the patient's heels elevated while in bed postoperatively, avoid heel ulcers. We want patients getting dressed in their normal clothes as quickly as possible. We want them feeling better, getting in their normal clothes, getting ready to go home, out of bed for their meals. We don't want them laying in bed. As soon as they're able and safely capable of walking to the restroom, we want them to ambulate with a walker or crutches to the bathroom and not using a bedside commode. So with activity and therapy, these are some of the activities we like to do after surgery. So supine to sit, going from a laying to sitting position, transferring from the edge of the bed, sitting to standing. These are all things we take for granted before surgery, but are things that you need to have the patients actively aware of the safe way to do this. Gait on a level surface, distances and devices used for the patients, how far are they walking, how many stairs do they have at home, have they graduated that program after surgery. Transferring off of a toilet, toilet hygiene, washing, dressing, showers and tub transfers, home training. These are all things that patients need help with or education so they're able to go home safely. Exercises with a physical therapist. You have ankle pumps, quad and glute sets, heel slides, straight leg raises, short arc quads, abduction and adduction exercises, extension exercises, hamstring stretches, sitting flexion, looking for quad lags, endurance. We want to have instruction to set up elevated toilet seats for the patient. We also like patients to transfer getting in and out of a car. Depending on what type of car they have, that can be very difficult for them. So with our education again begins before surgery and continues throughout the spectrum. We want to teach the patient what is the incentive spirometry, what is a deep breath, what is a good cough, what is the pain management program that we're using. We may be implementing all of this pain management to the patient, but they may not understand and they just take the 12 pills that we give them. They need to understand what each pill is, what each pill does, so they can help take control of their care. What are the side effects of these medications? How much weight bearing can the patient place? If it's a revision surgery, maybe they're only touchdown weight bearing or 50% weight bearing. Patient needs to be aware of that. They need to understand what is toe touch weight bearing, what is 50% weight bearing. They need help and education on how do I dress, what type of shirts are best to put on. Bathing, if they're on Coumadin, we need to give them Coumadin education. And then all of this education is also important for the coach or the family member. A lot of our patients are elderly, needing knee and hip replacements. It's just as important for their partner to hear having 4 ears or 2 sets of ears is better than one. And if one person misses any of the education, hopefully their teammate can be there to help pick that up. Discharge planning. So discharge planning, again, this starts before surgery. A lot of these patients may have heard that their friend went to a skilled rehab center and they think the skilled rehab center is like the Ritz-Carlton and that's where they're going to go and that's what they need to do and there's no other decision about it. But the reality is there's very good data that shows going home leads to a quicker recovery. And when you educate the patient and let them know that we can send them home and we can actually have therapy and care come to your house, that from a perception standpoint almost seems like a more VIP treatment than going to a skilled rehab center, and ultimately that's what they want after surgery. They just want to know that they're being taken care of. So if we can safely take care of them at home and get them away from other patients maybe recovering from pneumonias or other infections, that's going to help decrease their risk of getting any community-acquired infections. The ongoing needs at discharge and noting any variances. So before surgery, we can come up with a tentative game plan for these patients, but that can change. So maybe they're not mobilizing as well as we would hope after surgery. If home's not a safe environment, then a skilled rehab facility is the second best place to go. We want to have home equipment established and set up again before surgery, ideally, so they're not scrambling and maybe delaying a discharge, because a delayed discharge for a patient is going to delay the time for that patient who just had surgery that same day from going upstairs and getting the physical therapy they need and the mobilization they need. So again, throughout this whole continuum, our main goal is patient safety. We want to make sure through all of this, with this rapid recovery and enhanced recovery model, that the safety of the patient is maintained. We want to identify for any fall risks. We want to talk to the patient about fall risk assessment before surgery. Do they have slippery rugs? Do they have any areas where they may need to put a handrail in their house? These are all things that if they do before the surgery, they're going to be much more willing, capable, confident, with less anxiety to go home afterwards. So postoperative day 0, our ultimate goal, taking the big picture, taking a step back, we want to get our patients up, mobilizing, and walking. On average, it takes about 3 physical therapy sessions until a patient can safely be discharged home. If they don't get therapy for any reason, then their length of stay is going to be lengthened. So reasons why they may not ambulate postoperative day 0, if their pain's not well controlled, we need to make sure their pain's controlled. Are they nauseous or are they vomiting? Are they voiding? Bladder scan protocol, what's their blood pressure? Hypotension. Those are all reasons maybe the patient's not getting up and ambulating postoperative day 0, and these are all areas that we are prophylactically trying to counteract and can be very aggressive with the treatment. Another big area on postoperative care is that comorbidity optimization. Postoperative day 0, when you're getting that patient assignment, you want to briefly review their chart, because every patient's not the same. Every knee replacement's not the same knee replacement. They may have special medical problems or comorbidities that may require just a little extra attention. Sleep apnea, for example. That person probably needs to be on a pulse oximetry overnight that first night. If they have a CPAP machine, maybe they need to bring that in. If they have BPH, they're at an increased risk of urinary retention. So that bladder scan protocol is extremely important to ensure that they're not getting a neurogenic bladder. If a patient was on preoperative narcotics before surgery, our normal pain management algorithm's probably not going to work for them. And that's something, if you identify postoperative day 0, even before the patient has hit the floor, you're going to be able to aggressively increase that pain program to get their pain under control, ultimately, again, to get them ambulating that first day. Age greater than 80, on the flip side, you want to be cautious on the pain medicine. Maybe you're not as quick to increase that pain regimen if they're complaining of pain. Maybe you cut everything in half. We don't want to have cognitive impairment and increased risks of fall. Anticoagulation, if patients have previously been on anticoagulations, I'm sure you guys have seen this, where the orthopedic surgeon gives the DVT prophylaxis or the anticoagulant, the primary care doctor resumes their Plavix, and the cardiologist puts them back on another blood thinner, and now before you know it, you have 3 doctors and 3 different blood thinners, and you're wondering why the patient has a big hematoma the next day. So those are things, if you're able to identify that on day 0, get that clarified before they've had a chance to have 3 or 4 different anticoagulants, that's going to decrease the risk of bleeding, blood loss, hematomas, wound complications, and again, get that patient up and ambulating sooner. After surgery, it's certainly important to know, is it a knee replacement or is it a hip replacement? But again, big picture, big concept, you want to try to be thinking, why is the patient in the hospital today? Not what brought them in the first place, but why are they here today? Are they having any organ dysfunction? So did their BUN and creatinine go up because they had a renal insult, or maybe their blood pressure got too low, surgical stress? Are they hypothermic? Is their pain not controlled? These are all things that are preventable problems. Nausea and vomiting, again, that's preventable. Constipation, that's preventable. Cognitive dysfunction, sleep deprivation, are they not mobilizing enough? So these are all identifiable reasons that a patient may need to stay another day in the hospital, and these are all identifiable problems that we have the ability to treat as a care team. Blood management, fatigue, and then ultimately a discharge planning. So with our rapid recovery program, again, big picture, what's our goal for our total hip replacements? Patients are typically using a walker for 1 to 2 weeks. They're walking with a cane for 1 to 3 weeks, unassisted at 3 to 6 weeks, driving at 4 weeks. Maybe they can drive a little faster if the surgery was on their left leg. Returning to work 3 to 6 weeks, depending on the demand of their job. Golfing at 2 to 3 months, assuming they knew how to golf before surgery. Ski, hike, run, typically at 4 to 6 months. So functionally, patients can run after a hip replacement or a knee replacement. We don't typically recommend it just because of that high impact. There's a mechanical device in their hip, and that may decrease the longevity. With a knee replacement, so again, hospital stay 1 to 3 days, then home versus rehab. We like the patients to stand and begin walking the same day of surgery. They may start with a walker and then progress to crutches or a cane. There's pain after the surgery surrounding the muscles, and this usually ends in a few weeks or months. The exercise with physical therapy and also the exercise with occupational therapy is extremely important, part of the recovery process. After your surgery, again, you're able to play golf, walk, swim, bike, and dance if you knew how to dance before. The motion of your joint will generally improve. The extent of how stiff your joint was before surgery is based on what your stiffness was before surgery. So with a knee replacement, setting realistic expectations, range of motion is a big component. So if a patient's range of motion before surgery is 15 to 45 degrees, and they're expecting to have a 0 to 120 degree arc, their expectations are not realistic. They're never going to be met. Even if there's a perfect surgery, perfect recovery, we all do our job, they're not going to be happy. And at the end of the day, that's our goals. We want happy patients. The preoperative range of motion is the biggest deciding factor of the postoperative range of motion. And with knees in particular, while in the hospital, the flexion is not as important as the extension. Flexion comes as the swelling decreases, and if there's stiffness and flexion, manipulation procedures can be done afterwards. However, if there's stiffness in extension where they're not able to fully straighten their leg, that's very difficult and has not been shown to have good results with manipulation. So that extension is much more important that first week after surgery than is the flexion. And again, this is why we do what we do.
I'm Rebecca. I've been an operating room nurse for 30 years. It's what keeps me inspired in life. The pain is kind of a gradual thing. I talked to my orthopedic surgeon. He did an exam and said, looks like it's your hip. We went on our family vacation, and I looked at myself walking like this. So I booked my surgery. I had my first hip replaced in 2004, and the second one about a year later. It was great to get into the swimming pool, gradually getting stronger. Don't be afraid. Go see your doctor. It truly made me the person I was born to be.
Thank you very much. You guys have any questions? Yes? So on my elective hips, I do the anterior approach on almost anybody with the exception of extreme BMIs. So sometimes a patient's body habitus will prohibit us from doing the anterior approach if they have a large abdominal pannus that hangs over or drapes over that incision area. The increased risk of infection is higher than the benefits. But otherwise, doing all of my elective cases on the anterior approach. From a rehab standpoint, whether it's anterior or posterior, everything that we talked about today would apply. I didn't really want to differentiate between the two. No formal restrictions with the anterior approach. posterior approach, you can still go over posterior hip dislocation precautions, although there are a lot of surgeons now, and the data shows that if the posterior capsule is repaired, you don't necessarily have to have posterior hip dislocation precautions. That would be surgeon preference. One of the caveats to that with the anterior approach, because we're going in through the front and we're not cutting through any of those anterior muscle structures, we're stretching them, we do try to limit the active hip flexion or resisted hip flexion, as that tends to be fairly sore for the patient, at least for the first 3 to 4 weeks. But all of the other exercises would apply. Yes? As far as how long? So the American Academy of Orthopedic Surgery in our journal just a couple weeks ago just came out with a meta-analysis of total knee replacements. And we're starting to get more data as there's been registrars. The Australian registry is probably the longest standing, so it has the most data. But it was showing with a total knee replacement at 25 years, there was an 87% success rate. And for a partial knee replacement, it was 73%. So this was just, I haven't even had a chance to update my PowerPoint slide because it was just presented. Historically, we tend to quote 15 to 20 years. That's if you talk to most surgeons, on average, they'll say 15 years. That's because the polyethylene that was used 15 years ago, that's as far as we had from our research or our data. Hip replacements tend to last a little bit longer than knees, but we haven't had a meta-analysis on those registries, so I don't have any 25-year data. We do know the current implants that we're using, the historical limiting factor for both knee and hip replacements was the polyethylene that we had on the bearing surface. That's what acts like the cartilage. Just like cartilage wears out over time, that plastic wears out over time as well. So in lab simulations, the newer plastics that we're using have excellent wear characteristics at 25 to 30 years. They weren't around 25 or 30 years ago, so we ethically can't quote those numbers, but we're still waiting for that to come in. The most recent publications on the total hip replacements, I think, is getting close to 15 years. I think it was 12. At 12 years, there was no measurable wear rates of the current technology that we're using, which was significantly better than the previous plastics. So we're thinking 20 plus years.
So it was meta-analysis for the breakdown of the manufacturers?
No.
Just overall?
It just was an overall. But they did try to differentiate between the total knees and the partial knees. Because again, historical data on partial knees, I was even taught as a resident, partial knees are only temporary, maybe 5 or 10 years until you get converted to a total knee. It's really a staging type of procedure. But this data, particularly from the Australian registry, is showing that in the right patient, they're lasting much, much longer. So in some instances, a partial knee may be all that that patient needs for the rest of their life. Hip resurfacing, as far as? Well, the previous resurfacing technique was using a metal-on-metal bearing surface. So the bearing metal-on-metal, there's been some bad outcomes with the metal-on-metal, getting adverse local tissue reactions or alveolar reactions. So they've gone away from that resurfacing. The Birmingham hip, for example, it was metal-on-metal. Now, the data shows actually the Birmingham hip was not having the same reactions as the other manufacturers that did the metal-on-metal technology, but because of that, just in general, metal-on-metal has gone out of favor within the orthopedic community just for that risk. The biological aspect, everyone asks me in clinic, is there an injection you can give me that can just regrow all of my cartilage? And the answer is yes, but you're not a rat or a mouse or a goat, so we're not allowed to do it to you. So there is that technology is in the makings. The reality is it's probably 25, 30 years before it would be introduced to us, to humans, and we still don't know if it's going to work. So there's two mainstay injections that are approved for arthritis: cortisone injections, kind of the tried and true, or the visco supplementation, or the chicken shot. It got the name the chicken shot because in the 80s when it was invented, it actually was derived from the rooster comb. That's as much as I know about that. I don't know who was testing a rooster comb and injecting it in their knee to see how that works, but that's how it got the chicken shot. The data is mixed on that, and it depends on how much or how bad your arthritis is. So in the mild and moderate arthritis, the effectiveness on those injections is much better. Once you get to the advanced stage, unfortunately, all of the treatments we have don't typically give enough pain relief. And that's our ultimate goal with any of these procedures, including our non-operative treatment, is pain relief. If you have advanced arthritis and we can get your pain under control without surgery, then you don't need surgery. And that's ultimately what our goal is, to get rid of that pain so you can return to the activities you enjoy. Any other questions? All right, well, thank you very much.